I think we've had quite a few people join already, so we might just get started a little early today. Thanks and good morning, everyone. So today we have a very special session with our fellows debating a very important topic on how to manage optimal management of chronic total occlusions. But before we turn it over to our fellows and their mentors, we have a quick announcement that with the waning surge of COVID, there has been an interest in being able to have an option of hybrid grand rounds. It's still in flux about when we will be able to do this, but we expect that as this month goes on, we might have at least 1 or 2 sessions being offered in a hybrid format, and the hybrid format would be that there would be a limited number of attendees at the main grand rounds presentation, and then an option of Zoom participation will be available as well. And we will send out emails before each session informing in advance so that you can plan accordingly to visit. What we have today, as I mentioned, is our fellows debate. We have Matt Griffin working with Dr. Samit Shah, Krina Shah working with Dr. Glenn Henry and Yusuf Ahmad, and Ricardo Avendaño working with Dr. Roland Assi. And what I expect to be a very engaging discussion. I hope we get a chance to discuss this topic at the end. So I'm going to hand it over to Matt and Samit.
Thanks so much, Rohan. I'd like to just take a minute to introduce Matt, who's really put together an incredible presentation today. So Matt received his bachelor's degree from Johns Hopkins University, where he was an All-American basketball player. He then received his medical degree from Brown. And then he came to Yale for internal medicine residency, where I got to know him, and he was such a remarkable person. As a resident, he ran the refugee health clinic, and then we were lucky enough to keep him for a cardiology fellowship, and then he did a T32 research fellowship with Jeff Testani, and he's really been incredibly productive. So he is going to talk about medical management for coronary chronic total occlusions, and I really think his presentation will be unmatched today.
Man, thanks for that kind introduction to me. Actually, Krina is going to start first, but thanks a lot for that introduction.
Yeah, sorry to switch it up on you. I'm not sure if I'm sharing the right screen. Do you guys see the PowerPoint or the presenter view?
The PowerPoint.
Okay, great. So good morning, everyone. I'm Krina. I'm one of the second-year fellows. As Rohan mentioned, we wanted to talk about the optimal management of coronary CTOs today. I think as a group, we have no disclosures. I'm going to start with an overview of CTOs and then talk about PCI and indications for revascularization. Ricardo will follow with surgical approach, and then Matt will discuss the medical approach, and our mentors here will hopefully help us with some closing remarks at the end. So to start with, just a case to get our clinical juices going, a 60-year-old man comes with dyspnea on exertion. He's found to have a lateral perfusion defect on nuclear stress testing, predominantly scar, and then coronary angiography demonstrates a left CTO and otherwise non-obstructive disease. So he comes to you in clinic. Where do we go from here? Just some background to start with. I think we all know what a CTO is, but for the purpose of studies that were done on CTOs, it's a lesion with TIMI zero flow that's been there for greater than 3 months based on either symptom history or angiographic appearance. The incidence is about 5 to 30% based on the population or registry that you look at. And the first thing I want to say about CTOs is explicitly to say that they're not good. So that the presence of a CTO is associated with poor clinical outcomes. And there's a little bit of a misconception that they might be more stable than other type of coronary lesions or maybe benign in some way, but they absolutely are not. First off, they are independent predictors of mortality. In 2,000 patients presenting with STEMI at one center, those who had multi-vessel disease, including a CTO, had worse outcomes, specifically increased mortality associated with, increased mortality compared with those with multivessel disease without CTO or single vessel disease. And then this is another registry kind of saying the same thing or confirming the same thing. Again, 2,000 patients who presented with STEMI. Those who had CTO had worse mortality compared with those who did not have CTO, all of them having multivessel disease. And this is 5 years out. On the right side, they excluded early deaths within 30 days and still saw the same issue. Next, CTOs are also associated with increased ventricular arrhythmias. So in this study, they looked at a little over 400 patients who had ICD placement for secondary prevention, and those who had CTOs had more recurrent ventricular arrhythmias and associated appropriate ICD shocks than those without, even if multivessel disease. And then finally, we often see CTOs with really nice collaterals and think to ourselves, great, this person is perfusing their myocardium. But in this study, they measured the FFR of 62 patients with angiographically well-developed collaterals and without like Q waves on their EKG, presumably no infarct. And you can see the FFRs were incredibly low, less than 0.8 across the board, suggesting inadequate flow to that region. And just again, does the visual appearance of these collaterals even matter? The same group later compared different degrees of collateralization. So CC0 here being poorly developed collaterals versus CC2 being very well developed collaterals, CC1 being intermediate ones, but there really was no significant difference in the FFR across the board, suggesting again that these patients and the affected myocardium supplied by the CTO is persistently ischemic, no matter the angiographic appearance of collaterals. And for what it's worth, these FFRs do seem to normalize to the same degree as other lesions after PCI. So we do have an ability to essentially normalize with PCI. So then even with poor outcomes and significant prevalence, revascularization is considered for only a small proportion of patients with CTOs. So again, I talked about 5 to 30% of patients referred for angiography have CTOs, but we don't intervene in the majority. In some registries, it's about 30% total revascularization, whether PCI or CABG, with PCI only seeming to account for about 8 to 10% of all CTOs. And I think some of this is due to the increased technical difficulty of CTO revascularization by PCI. Historically, we've had low procedural success. The NCDR reported outcomes from 2009 to 2013. And while they were slowly improving in those years, we were still only averaging about 60% success with recanalizing CTOs. And part of this is operator experience. So to state the obvious, the more experience you have, the more volume you do, the better you are, and then the less complications you have. So in the same time period from the same NCDR data, you can see that high volume CTO centers, the success rate actually approached 90%. And then we actually have improved our technique and equipment over time. So the details of which are kind of beyond the scope of today's talk, but the hybrid algorithm here on the left is a more protocolized approach to CTOs that came out in 2012, recommending for dual injection universally to allow for a more adequate assessment of lesion anatomy and to inform our approach. So then with use of this method, you can see the total success rate actually went up to 87% from 2012 to 2017 as per the Progress CTO registry. So yes, we've had poor success in the past, but this has improved significantly. The other issue is that there's high periprocedural complication rate, and this is a legitimate concern. So depending on the registry, this is Progress CTO on the left, Open CTO on the right, there's about a 1% mortality rate, up to 10% perforation rate with 1% tamponade. There's high stroke rates, high periprocedural MI rates as compared to other PCIs of like more straightforward type A lesions. And so this is something we obviously need to be thinking about, but some of the frequency depends on the approach. So a retrograde approach is associated with increased complications, including in-hospital MACE and perforation when compared with antegrade approaches. And so can we predict who needs which approach? Yeah, maybe. There have been the development of several risk scores to help assess lesion complexity. And this is the Japan CTO score. This one specifically was developed to estimate the likelihood of successful guide wire passage through the CTO within 30 minutes and is classified into easy, intermediate, difficult, very difficult. And while higher scores were originally designed to predict procedural times, they're also associated with increased technical failure rates. But also you can kind of predict who might need which approach with them. So the higher the CTO score, you can see the more likely use of retrograde approach and therefore more likely higher procedural risk associated with those for those patients. So this is information that we can use to inform procedural risk before even thinking about PCI for patients. So all that said, I want to say that with these improved techniques, both in terms of procedural success and recannulization, but also in terms of complexity assessment and risk assessment, our approach to CTO should be similar to that of other stable coronary lesions. And so first off, we should definitely revascularize CTOs to improve angina and quality of life. Based on the 2021 ACC revascularization guidelines, there is a class 1A recommendation to revascularize patients who have significant stable CAD with refractory angina despite medical therapy. But there's only a 2B recommendation for the same patients with CTOs. And so I'm going to talk through a little bit of data just to say that I think this should be a stronger recommendation. So first, there's a bunch of registry data to support this. And this is one of multiple multi-center registries. Here, they looked at 1,000 patients who underwent CTO PCI with a success rate of about 86%. And there were significant improvements in all domains of the Seattle Angina Questionnaire, the Rose Dyspnea Scale, and the Patient Health Questionnaire at 1 month post-PCI. But okay, that's observational data, that's fair. So then what about RCTs? So here in the 2018 EuroCTO trial, they looked at 396 patients, and these folks were randomized to PCI plus optimal medical therapy or medical therapy alone. Unfortunately, this trial failed to recruit the number of patients they originally wanted to, but they still showed that with PCI, there was a significant improvement in the SAQ domains of anginal frequency and quality of life at 12 months. Additionally, there was the percentage of patients in the PCI group who had significant improvement themselves were greater in multiple domains, including these two, and physical limitation and freedom from angina. The one thing I will note is that EuroCTO randomized patients after they treated other non-CTO lesions, and so this allowed them to look at the effect of revascularizing the CTO itself. And the reason I mention this is because the subsequent larger trial, Decision CTO, did not demonstrate a benefit in these domains. And the difference in when they revascularized their non-CTO lesions may be part of that, part of the reason they didn't show a benefit. So in Decision CTO, there were 834 patients who were randomized to CTO versus PCI versus no PCI of CTO. And after randomization, patients received PCI of all their lesions, including the CTO, or just the non-CTO lesions alone. And so if you think about the treatment benefit that they're comparing, they're still benefiting. they're still comparing PCI in many patients. And so here you can see that in the patients in the non-CTO PCI group, 50% still actually got PCI. And then the other issue with the study is 20% actually crossed over to the CTO PCI because of near immediate symptoms refractory to medical management. So I think all this kind of confounds the data and the ability of decision CTO to really comment on anginal benefit. And I think we should be offering patients CTO PCI for refractory angina. And so that patient in the beginning, 60-year-old guy with dyspnea, if he had persistent dyspnea despite medical therapy, I would personally recommend PCI for that patient. So what about other indications? So I guess I might consider revascularizing CTOs to get complete revascularization. So this is from the COMPLETE trial that we all know very well. After STEMI, complete revascularization improves outcomes at 3 years. In this study, operators were instructed to revascularize CTOs if they were experienced and had likelihood of success, and about 2% of the bypass lesions were CTOs. So there's that to start with. And then more data for complete revascularization comes from the Syntax trial. So they did a post hoc analysis at which they looked at the 5-year outcomes for patients who got PCI, comparing them to each other based on their residual disease burden, essentially stratified by their residual Syntax score. So you can see here in purple, these are folks who had residual Syntax score of greater than 8, yellows 4 to 8, green is 0 to 4, and blue is 0. So those folks who had greater residual Syntax scores had worse outcomes at 5 years, including all-cause mortality and MACE. And then this is a different graph kind of showing the same thing, but in all these domains, patients with incomplete revascularization did worse. So now diving deeper into our specific area of interest, they actually found that having a CTO was the strongest predictor of incomplete revascularization. And when they broke down the patients who had CTOs to incomplete revascularization versus complete revascularization, the ones with incomplete also had increased MACE. So does this mean we definitely do it for all patients who come in? I think we consider it. If they're a lower risk patient with a lower complexity lesion, then yes, let's revascularize for them because these outcomes show that they're going to do worse without complete revascularization. The next area that we think about revascularizing for is to improve LV function. This is a 2015 meta-analysis of studies evaluating EF before and after CTO PCI, and there was like a 4.7% increase in EF in the meta-analysis after CTO PCI, but these weren't RCTs, unfortunately, and the quality of the studies were probably not as good as we would like them to proceed with high-risk procedure. And so there is more recent RCT data from the EXPLORE trial and Revasc trials that actually don't show any significant benefit in EF. Post-PCI as compared with medical therapy alone. There, I will say, was a subgroup analysis of EXPLORE, which looked at LAD lesions versus non-LAD lesions, and there was a signal for benefit. So I think this is definitely an area that we should explore in the future. I will also note that the RCTs both had median EFs that were only in the mildly reduced range. And so the reason I mentioned that is because there is this other study that looked at low EF, less than 35%, and felt, again, this is an observational study as well, there was a benefit in those patients. But the point being that I don't think we have definitive data to improve for, to revascularize for improvement of LV function. But there are some areas that we probably need to look at more closely, like low EF populations and those with LAD CTO. And then finally, maybe we think about reducing large ischemic burden, maybe. So in this one center in Amsterdam, they looked at the degree of reduction of ischemic burden and found that there were better outcomes when folks had an extensive ischemic burden reduction. And so they defined that by PET imaging and greater than 3 segments of improvement or improvement in myocardial blood flow. So I think this is an area that is pretty controversial, and ischemia taught us that reducing ischemic burden alone, despite size, doesn't really improve outcomes. So I would say maybe this isn't the area we revascularize CTOs for. So in summary, I want to say that, again, CTOs are associated with poor outcomes. I hope I've convinced you of that. But additionally, with improving CTO assessment and PCI techniques, we should use the same standards to revascularize a CTO as for other stable lesions. Specifically, we should definitely offer them to patients with refractory angina. In other patient populations, we don't have as strong evidence, I think, for improvement of heart outcomes, but the existing RCTs do point to certain folks that we should be thinking about and studying more critically. And those are probably those with high ischemic burden, low EF, LAD disease. But at the end, safety is everything, and PCI for all patients carries risk and greater for CTO PCI despite the improvements. So we definitely need to be thoughtful about who will actually benefit from revascularization, recognizing that there are these upfront risks. So I'll conclude here and let Ricardo and Matt tell you the other parts of the story. I just want to thank Dr. Henry, Dr. Ahmad for their help putting this together, and obviously Matt and Ricardo for hopefully being kind with their counter arguments.
Thanks, Krina. Let me share my screen.
Ricardo, you're going next?
Yeah.
Okay, so good morning, everyone. It's my pleasure and privilege to introduce Dr. Ricardo Avendaño, who earned his medical degree from Dr. Jose Matias Delgado University in San Salvador, El Salvador, and graduated cum laude. He then did his residency in internal medicine at Albert Einstein in New York, and then came to Yale for a combined research and clinical fellowship in cardiology. And Ricardo has plans to pursue a career in clinical cardiac electrophysiology. He is currently interested in the intersection between cardiovascular imaging and cardiac electrophysiology. It's been a great experience working with Ricardo over the last few months, and particularly on this presentation. It was extremely educational for me, and I'm sure it'll be extremely educational for everyone else.
Thanks so much. Let me just finalize sharing some issues. I'm sorry about that. Are you seeing the presenter view or no?
Yes.
Okay. Okay, so thanks so much, Dr. Asi, for your kind introduction. Today, I will talk to you about the surgical approach to the management of CTOs. I will go over the importance of revascularizing CTOs, the evidence between medical therapy and bypass, the evidence between PCI and bypass, and what is a hybrid approach. I have to agree with Krina. I know she convinced you, and I agree with her that the symptoms, there's a reduction in symptoms, ischemia and VT-VF incidence, and also mortality when we revascularize these lesions. But also, I would like to mention that from a surgical perspective, the management of CTOs should be no different than the management of chronic stable coronary disease. And that is why I'm going to show you the evidence that supports surgical revascularization versus medical therapy. Initial studies actually showed mortality benefit when we compared patients with revascular disease versus the medical therapy at the era. Initially, the coronary artery surgery study, the VA study, and the European coronary surgery study, they all showed that there was a mortality benefit in surgical revascularization versus medical therapy at 5, 10, and 12 years. And although, of course, that was in the 1980s, more contemporary data did not show that benefit, particularly the Barry 2 trial and the MASS trials didn't show any benefits in revascularization. The Ischemia did not show any benefit in revascularization, even though they didn't evaluate surgical revascularization versus medical therapy. However, there was a recent meta-analysis published last year in where they basically showed in the available evidence of up to date that revascularization, irrespective of surgical or percutaneous, in addition to medical therapy, was associated with a decreased risk of mortality. And as you can see this in the bottom, this association appears to be stronger when surgical revascularization was used. Now, this is going to lead us to the next question. If we know that revascularization is better than medical therapy alone in treating chronic stable coronary disease, then which one is better, bypass or PCI? I don't think that there's such a controversy because up until the 2000s, we didn't have much data, and the majority of the data that was used to support the use of PCI in chronic stable coronary disease was derived from surgical revascularization data. With this context in mind, Syntax trial came to play, and basically this was a randomized clinical trial of 1,800 patients that evaluated patients in all comers approach with three vessel disease or left main disease that were randomized 50% to PCI, and I have to note that the taxes or the first generation stents versus surgical revascularization. 28% of them were diabetics. 33% had left main disease, and they had a high stent burden, almost 5 stents per patient. The primary endpoint of the study was a composite of MACE, with secondary endpoints were death, repeat revascularization, and stroke or MI. So as you can see from the figure shown here, there was a significant reduction in the primary endpoint at 1 year in the bypass group. And that was deemed to be likely driven by a lesser repeat revascularization when compared to PCI. But one of the key lessons that emerged from Syntax was that Syntax score was emerged. And that basically is an anatomic assessment that we use to classify severity of the lesions with multi-vessel disease. And as you can see from the figure on the left, patients with a higher complexity, as evidenced by a higher Syntax score, did actually better with surgery as opposed to PCI. And these results appears to hold at 2, 3, and 5 years. Also, at 10 years, a recent analysis of the same data showed that patients with 3 vessel disease, but not left main disease, had mortality benefit over 10 years. Of course, this is up to the extent of physical limitations and quality of life that has shown to be worse in bypass as opposed to PCI in the first months preceding after surgery, which has been one of the main criticisms of surgery, of course. Similarly, in a more contemporary clinical registry study, evaluating the second generation stents, in this case, everolimus stents, in where they noticed that patients who underwent PCI versus bypass actually had higher rates of MI and revascularization as opposed to bypass. There was no difference in the rate of death in the 2 groups. What about patients with diabetes? Well, the performance of bypass in patients with diabetes in CAD had already been shown in subgroup analysis of the Syntax trial. The Freedom trial actually answered this question in its entirety. They basically enrolled 1,900 patients in a multi-center fashion with intermediate to high risk syntax in average. And they evaluated mostly first generation stents, but also second generation stents were used. And they noticed that there was a significant reduction in all of the groups, irrespective of the syntax score in death, MI, and revascularization at 2 and 5 years. And but of course, with a higher rate of stroke in the bypass group. And how does CABG perform in left main disease? Well, the reality is that up to this date, many studies have been done, but the general consensus is that surgical revascularization, it is associated with a lower rate of MI and a lower rate of MI. Yes? Okay, it was associated with a lower rate of MI and also repeat revascularization. And while the Excel trial was the only one that showed the mortality benefit in this population, this recent study by the TIMI group did not show any significant difference. Although, as you can see from the graph here, it appears that over time, it favors bypass surgery as opposed to PCI, of course, not significant. But now you may be wondering, so why or what is the role of CTO in outcomes? And I think that Krina was really clear about this, that CTOs have adverse outcomes overall, but how we can analyze this from the surgical perspective. The truth is that there's not much data, because from the surgeon perspective, it doesn't really matter if you have a CTO, even though in general, it is associated with worse outcomes. The lesion in its entirety is gonna be bypassed. But I found this paper that actually Krina already showed you that they tried to answer this question. So this was a subgroup analysis of the syntax group, syntax trial that basically showed an analysis of how the CTOs impact outcomes at 4 years. So as you can see here on the left, there's a figure that demonstrates the procedural success rates in patients who had CTOs on an intention to treat basis. More CTOs were actually bypassed in the bypass group, almost 70%, versus the PCI group, 49%. And on the right, you can see that irrespective of the group, incomplete revascularization on blue on the PCI and the bypass group was actually associated with worse outcomes at 4 years. My main takeaway from this trial is that irrespective of the group, CTOs are really difficult to revascularize. Now, let's hypothesize, because Krina showed you a lot of data. And as an interventionist, she could argue, well, stents last actually longer than grafts, particularly vein grafts, because this is a question that has raised many times. So let's say, for example, if 100 patients who have CTO underwent PCI, based on the Decision CTO trial or the Progress CTO trial, almost 90% of them will be stented. And at 1 year, almost 80% of them will be patent. Okay. Now, let's say, for example, if the same group of patients underwent surgery, based on the study that I just showed you, almost 70% or 68% of those patients will have a graft. And based on the PRAC-4 trial, if the vein grafts were done, about 23% of them are going to be patent at 1 year. So this basically raises the question if a graft patency is something that we should be really concerned about. I would say that not really, but the evidence is as follows. Limas, I think that they are great. They actually have a patency rate of more than 90% at 1 year, and some studies have actually shown more than 90% at even 20 years. And they confirm mortality for reasons that we don't even know. Vein grafts, in the other hand, they range anywhere from 50 to 60% or 40 to 60%, depending on if on or off pump grafts are used or are done. And also at 20 years, it varies, but the evidence available shows anywhere from 20 to 50%. Additionally, there's an association between CTOs and bypass that has been raised over time, in where there's a thought that maybe bypass actually produces more CTOs down the line. And there was a study that actually showed some evidence on that. And what I think is interesting from this slide is that vein grafts are more commonly used in RCA and circumflex, and they tend to have a higher rate of CTOs developments down the line when compared to the LAD that normally you use the Lima, normally or generally speaking. And the reasons for these associations are not fully understood. Now, this has led to ask ourselves if there's a role for multi-arterial grafting. And in this study, they actually showed that 2 or more arterial grafts are actually associated with a significant reduction in mortality with when it is compared to single arterial grafts, as you can see from this graph. But the problem is that this practice has not picked up, and questions remains about conduits and patient selection. So this leads us to what I think is key from the surgeon perspective in the treatment of chronic stable CAD, CTOs, because the reality is, as I mentioned before, it doesn't really matter if you have a CTO. What matters the most is the patient. You have to extensively analyze the diagnostic angiogram to evaluate the cap of the occlusion length, the vessel, being in the targets that you're going to go for, the side branches, if there's a presence of collaterals, if you have good conduits in each patient. For example, if you have a possible distal recanalization that you can do with an LAD endarterectomy, for example, or if you have viability. And for example, this is a case in where LAD endarterectomy was done. This is the Lima, this is a vein graft, and this is the anterior wall of the heart. And you can see how a patient who had good targets in the other vessels and LAD was not or didn't have a good target to begin with, but when the patient was actually in the operating room, they noticed that it was really calcified and they were able to perform an LAD endarterectomy, giving an excellent result postoperatively. Of course, evidence for this is still unclear, but this is something that we can consider. So with all of this in mind, you can see that the bypass surgery and also the PCI is not perfect. And I think that the hybrid revascularization is an approach that basically takes the best from both worlds, meaning that you can decrease the rates of strokes that are associated with bypass by performing minimally invasive approaches. And you can actually provide long-term patency rates of arterial grafts, such as the Lima. So for example, if we can take the patient that Krina mentioned in the beginning, we know that this patient had an LAD circumflex CTO, so they could do the PCI of that. And if the angiogram shows that the patient has other lesions as well, then surgical revascularization can be performed afterwards, or vice versa. The problem with this approach is that even though it has been shown to reduce or to be non-inferior to bypass surgery in MACE over time, its practice in the United States in major academic centers has not picked up. In this study from 2014, less than 1% of the cases in the United States were considered to be hybrid. So I would like to conclude by the following. I think that CTOs from the surgical perspective should not be the deciding factor as to whether performing surgical revascularization or percutaneous one. I think that better data is needed to further evaluate the optimal strategy in this population. I think that incomplete revascularization is associated with worse outcomes. CABG and better PCI are better than medical therapy alone, of course, with increased perioperative risk. CABG offers the best durability, outperforms PCI in the treatment of chronic stable CAD, particularly in patients with multi-vessel CAD, left main disease, and diabetes, irrespective of the complexity of the lesions, and those particularly with low EF and a higher stroke risk, of course. Multi-arterial grafts should also be considered, and alternative therapies such as LAD endarterectomy or hybrid approaches should be also considered. Thank you to Dr. Asif for many meetings, and Dr. and my co-fellows, Krina and Matt. Thanks.
Okay, just give me a minute here to share and presenter view. Okay, can you see my screen, or is this just presenter view?
Presenter.
Matt, it's just presenter view. In Zoom, you just have to do a custom share. So just change your Zoom share so you can just show the part that you want to show.
Okay. So hopefully we're good there.
Yeah, looks great.
Okay. So I'm going to argue that the majority of these patients with CTO should be treated with optimal medical therapy. And I want to first focus on PCI for CTOs, specifically the harms and the benefits. So I'll start by quantifying the procedural risk for CTO PCI. And then I'll move on to show the absence of benefit with respect to objective endpoints, including mortality, and an uncertain benefit with respect to symptoms. I'll discuss some potential mechanisms to explain this limited benefit, and then wrap things up by talking about patient selection strategies. So before jumping into the data, I just want to put CTO PCI in perspective relative to medicine as a whole. This is a theoretical plot from an older CERT paper where benefits on the y-axis and cost is on the x-axis. And on the steep part of the curve, we have things like public sanitation measures, mass vaccination campaigns. Around the inflection point, we have things like pacemakers for symptomatic bradycardia and valve replacement. On the flat part of the curve, we have things like wireless pressure sensors in select patients with heart failure, which may reduce hospitalizations, but at significant cost. And I would argue CTO PCI is somewhere out here, which is not to say that it doesn't have a place, but we should be pretty selective about who we recommend it to. Diving into specific studies, I just want to highlight the risk of CTO PCI in the real world. So one of the strengths of registry data is external validity and the ability to capture a large number of events. And this is a recent article from Zane et al. In Circ Interventions looking at 7,000 attempted PCIs across the state of Michigan from a Blue Cross Blue Shield database. They did not compare CTO PCI to medical therapy, but just attempted to quantify the absolute risk of the procedure and procedural success rates. Given the robust sample, they were able to stratify outcomes by both center and operator volume or experience, which is important in any technically complex procedure like CTO PCI. So here we see a table of procedural outcomes, and there are a few things worth highlighting. In this first column, we see the lowest volume operators, so those that performed less than 12 PCIs a year, followed by the intermediate group, and then the highest volume operators all the way to the right, who performed at least 34 CTO PCIs a year. The other thing is MACE is not just biomarker MI here or increasing diuretics as an outpatient or anything like that. It's a composite of death, urgent CABG, stroke, or tamponade. So pretty significant. I wouldn't call any of those outcomes soft. The rates of death were equivalent between the lowest and highest volume operators, which at first is somewhat counterintuitive, given that with any, again, technically complex procedure, higher volume operators have better outcomes. But then looking more closely at who the patients selected, more experienced operators took on more complex cases. So the patients were older, had higher prior rates of MI and CABG, as well as heart failure. But really the main takeaway from this is the absolute risk of death across this pretty large representative sample was 1.5%, and for the highest volume operators, 1.7%, which translates to a number needed to harm of 67 for death alone for any attempt at CTO PCI. So to better quantify the benefits of CTO PCI, there's just a couple of studies I want to focus on. So first, there's been several retrospectives that suggest a benefit with regard to symptoms and mortality specifically. So on the left here, this is the Korean retrospective study that looked at about 2,000 patients at a single center over 10 years, and this is just patients undergoing CTO-PCI. And they found that those undergoing revascularization had an absolute risk reduction of 7%, which translates to number needed to treat of 14 for mortality. On the right is the Canadian registry that looked at 1,600 patients over 10 years. And here they grouped CABG and PCI together, but they still found an absolute risk reduction of nearly 14%, although that was somewhat attenuated when looking at just PCI. Still claimed a significant mortality benefit with a number needed to treat of 8. So, just looking at the registry data, you think this magnitude of benefit should make it relatively easy to power confirmatory RCTs. And before diving into the RCT specifically, I just want to talk about study design. So a few slides ago, I spent time touting the validity of retrospective registry data when looking at procedural outcomes, but these studies are not ideal when comparing therapies, in this case, optimal medical therapy and CTO-PCI revascularization due to residual and measured confoundings. And this is hopefully an example that will elucidate that. So you have 2 patients which will look the same in registry data, matched with respect to age, sex, renal function, ejection fraction, and BMI. But qualitatively, I think we can tell that these are different patients. So the first patient is active and was diagnosed with a CTO after a stress test, which he may not have needed, for pre-op hernia repair, and is tolerating maximal doses of GDMT to treat his reduced ejection fraction. Whereas patient 2, on the other hand, has severely limited mobility for several years from orthopedic issues, and instead of hernia repair, is scheduled to undergo sacral wound debridement and tolerating minimal doses of medications for HFrEF. And it's not just that patient 1 has a better prognosis due to factors that are hard to quantify in registries, but these same factors make him more likely to be revascularized, which heavily biases registry data and makes it somewhat unreliable for quantifying things like mortality in a comparison fashion. So as you can guess, the RCT data for CTO revascularization did not meet these high expectations from the registry data. And I'm just going to briefly talk about 3 studies before going into more detail on the 4th. So just kind of in sequence, there was Explore CTO that looked at 300 patients with a CTO discovered during STEMI, and in the surrogate endpoint of ejection fraction, there was no improvement at 4 months. EuroCTO looked at about 400 patients and found that PCI did lead to improved quality of life, but no evidence of mortality benefit, although it was somewhat underpowered. And then Decision CTO, which studied 830 patients, which is larger than the 2 previous studies combined, and they found no difference in survival or quality of life at 5 years. So, we can say we don't have the data to answer the question about mortality in CTO, but I would argue we have 3 RCTs that very mixed results, none of which show anything approaching the mortality benefit. So given this background data, I just want to spend the last few minutes discussing the CTO sub-study of the Ischemia Trial, which was presented at AHA, and the manuscript is in press now. So this is by Bangalore et al. They studied patients who had CTOs diagnosed by the coronary CTA as part of the larger Ischemia Trial. This was the largest study to date, which with almost 1,500 patients with CTOs. They looked at objective outcomes as well as symptoms. And as Krina highlighted, patients with CTOs on the whole were much sicker than patients without CTOs. So what did they find? Again, 1,500 patients. And just to orient here, this is a figure displaying the hard outcomes. So you can see the the endpoint is listed, and then CTO followed by, or non-CTO rather, followed, and CTO underneath directly. And then in the middle of the screen, you have a forest plot where points to the left favor invasive therapy and points to the right favor conservative therapy. And in short, we see no endpoint favoring an invasive strategy for CTO. And in fact, every confidence interval crosses 0 except for procedural MI and heart failure, which actually both favor conservative therapy, although procedural MI would be expected in all fairness. So heart outcomes, no benefit. And then looking at symptomatic improvement. So given the large number of subjects enrolled here, these differences are significant. So CTO is on, conservative therapy is on the left, invasive strategies are on the right. And these are statistically significant. So a score of 74.2 is worse than a score of 73.1 in a study of 1,500 patients. That being said, I would say the magnitude of difference, a 1% reduction in symptomatology, is unclear, and have to ask yourself, is this worth, in every patient, is this really worth a 1.5% risk of mortality to achieve this benefit? So just mechanistically, I just wanted to touch on the reasons why patients with an ischemic burden may not have improved after revascularization, even though the mechanism is really appealing of improving blood flow in an area where there's not much blood flow. And I think a good parallel may be the treatment of heart failure with reduced ejection fraction. So directly improving blood flow, or in this example, ejection fraction, should confer a mortality benefit if it's in the causal pathway. But we know after many trials that, at least with respect to heart failure, that the exact opposite is true, that negative inotropes improve mortality where positive inotropes hasten death. And it may be similar for a CTO. So a CTO may not be in the causal pathway for some patients, but rather just a marker of disease severity. And this is a quote from an editorial by Dr. David Brown from WashU, who I think sums it up nicely when he says, focal mechanical treatments for diffuse diseases may be ineffective. And lastly, symptoms, the ischemic symptoms, especially in the case example, we listed a patient with dyspnea on exertion. It may be from an alternate cause, whether that's microvascular disease or something non-cardiac, where revascular and the CTO may be an incidental finding. So just a few points to leave everyone with. So CTO PCI carries a substantial procedural risk, even among experienced centers and operators. There's no benefit across several RCTs with respect to mortality, and the symptomatic benefit is uncertain in a given patient. And lastly, patients need to be highly selected. I think we all three of us would agree about that. And one possibility is the heart team approach that we have at the VA, which does make it into the guidelines here, that for patients failing optimal medical therapy, a heart team approach which includes multidisciplinary representation, may improve outcomes. So we can move on to closing remarks from mentors. I just want to thank Samit for his mentorship, not just this project, but for over the last 7 years we've known each other. And I selected this topic in no small part to be able to work with him. And also want to thank Krina and Ricardo for their help with this. And we can, if we have time, turn it over to the mentors for brief closing remarks before questions.
Yeah, I'll jump on quickly. I just want to apologize for not introducing Krina formally. I wasn't aware of that Yale tradition. I want to say, well done to all three presenters. I thought, everyone gave very, very good talks and compelling arguments. Matt, I think you can, save your slides and use them again for next time anyone wants to do a grand rounds on PCI for stable CAD, because, everything that you said regarding CTO PCI is true for stable CAD. And I don't think, anyone is doing CTO PCI to reduce mortality. I would agree on your comments about the heart team, which are very, very important. We work very closely with the cardiac surgeons, and there's a lot of cases that me and Roland will look at together. And, if we think that the patient will be best served with surgery and he can get them through the operation, they'll go for surgery. And then, we do quite a detailed analysis. If is unsure, he'll get a CT scan, and if the target doesn't look suitable, he might ask me, if it's possible to do percutaneously. I think that the Michigan data is a little disturbing for all of us. It's selected, it's from one geography, and it only goes up to 2018, and even in the highest tertile, that volume isn't particularly high, 30 CTO PCIs a year, and the success rates are still low, and they're lower than we would like and what we would expect. Some of the bigger, more organized registries like Progress, which look at more expert centers, the success rates are around 80 to 90%. And the last thing I want to touch on is safety. You mentioned the procedural risk, and I think you're completely right about that. And that's something, as a community, the people who do CTO PCI, there's been an increased focus on safety in the last few years. And I think there was a couple of years when people, were obsessed with getting the arteries open, and now we have, a slightly more measured approach. My personal belief is that the indications for CTO PCI are exactly the same as the indications for PCI for stable CAD, but the threshold for intervention needs to be higher because the risk is higher. So I think, you need to persist with medical therapy first. And if patients have truly refractory symptoms and they're willing and they understand the risks, then we offer them an invasive procedure. But yeah, I think everyone did a very, very nice job, and I want to congratulate all three of you.
Thanks so much, Yusuf. So Rohan actually had to jump off, and so I'll just kind of open it up to questions. And then I think while we're waiting for questions to come up, I'll just throw this out there. This is a question that Matt had brought up when he was putting his slides together, is how do we move towards standardizing patient selection? And are there scores kind of in place or in progress to help pick ideal patients that would benefit from an intervention?
I think that's a really good question. We have a plethora of scores. None of them are perfect. The one that gets used the most is the JCTO score, which I think Krina showed, which that it was initially shown to predict how quickly you could wire a lesion antegrade, but it does predict complications as well. And they are the normal things we look at for any angiogram, which is calcification, tortuosity. The CTO specific ones are, the configuration of the proximal cap, the length of the occlusion, what the distal vessel is like, and whether someone's attempted it before. Retrograde approaches are associated with increased hazard, although you have to be careful because sometimes a procedure, you have a retrograde approach, it has a complication, but that might be from the antegrade portion of the procedure. So that can be a little harder to tease out. And epicardial collaterals, we've learned as a community over the last few years, are clearly more hazardous, and we're trying to avoid them as much as possible. And we're looking at other techniques such as star techniques to try and reduce the risk.
Thanks. We have a question from Dr. Mani.
Very nice, actually, discussion. I really learned a lot from this group. And the question I have is that maybe I missed it, but I didn't hear from anyone that the duration of CTO plays any role. Whether, for example, after certain years, there's not going to be benefit, even symptomatic for the patient, and we can actually assign those symptoms to something else. Is that, for example, if you have somebody who has 5 years of CTO and opening that, is there any study showing that there is any cutoff for that duration of CTO?
That's a great question. So, Krina showed that data about the presence of collaterals not being protective against ischemia, but that's kind of a surrogate marker for the question that you're asking. And then I think the other things that people look at are ejection fraction and, scar, et cetera. But as far as I know, there's no data that quantifies the duration that a CTO is present and any potential benefit to intervention. Yusuf or Glenn, do you have any thoughts on that?
Glenn, I think you're on mute still.
Is that better? There we go. I don't think there's any data looking at the duration of the CTO as a predictor. It really is all about viability of the tissue served by that vessel. There is some data to suggest that after about 3 months, the CTO histologically is pretty well formed, which is why we use that time point cutoff to differentiate between a recent occlusion and a chronic total occlusion because of the fibrosis of the vessel and such, making passage of the wire more difficult. We also do know that post-CABG patients tend to have more difficult CTOs because they get arterial pressurization of the distal cap as well as the proximal cap, which makes them more difficult.
Roland, does the duration of a CTO change your decision when you're thinking about surgical revascularization?
Yes, I think, for a very, old CTOs, we really worry about the distal target. Like everything else in arterial vasculature, when you take off the pressure gradient inside the vessel, there's this expected atrophy or hypertrophy of the vessel wall. And for very long CTO, we tend to see less of a target to bypass. So that's what we take into consideration. However, a long duration CTO with a visible target distal to it will still be a candidate for bypass if we believe that the territory is viable.
Yeah, I think that the CTO literature is rife with examples of the significant growth of CTOs after revascularization. The problem is Roland can't see how big it's going to be when there's a 0.5 millimeter or 1 millimeter vessel there that's going to grow to 3.5.
All right, we're kind of at time. And so unless anyone else has questions, I'd just like to congratulate all of our presenters today. You all did a really tremendous job. And I thought it was an incredible discussion. So thanks to my co-mentors and the fellows for putting this great talk together.
It's very educational, everyone. Thank you.
Thanks, everybody.
Great work.